I'm going to talk about mistakes today, that they happen, that we need to accept that they happen, why they happen, and specifically looking at the human factors. Start thinking over in your mind, when did you last make a mistake? Hopefully we're not talking about a major incident, no SUIs, anything like that, but you should be able to think of one. It may not actually be medically related, although I'm sure that's probably where your brain's going. You may have forgotten something to bring to symposium. You may have taken a wrong junction off the M6. But think of something. For me, I was in an assessment clinic a couple of weeks ago, and I made a poor judgment on a case. We were really strapped. The clinic was supposed to be reduced. There was only 2, not 3 doctors in the clinic, but it hadn't, because that communication hadn't happened. Our stereo unit was being a little bit tricksy, and there was some calc. And I thought I could see this calc with ultrasound. So a little bit of textural change around there, so I biopsied it. Sod's law, no calc on the Faxitron images, it's a B1. Okay. She ended up having to come back a second day, a B2 final result. No harm was actually done. Am I being harsh on myself? Is this a mistake? Yes, I probably am being harsh on myself. I affected that patient's pathway. She needed 2 visits to get her final result. It was a B2. It increases her anxiety. It's everything we don't want to do in the screening programme. But we're perfectionists. That's what we do. We strive for perfection. So yes, I'm probably being harsh, but I think I made a mistake. But there are those that think that mistakes are a good thing. This is Henry Marsh. If you've not come across him before, he is a quite enigmatic neurosurgeon from London, from George's. If you want a good book to read, I would thoroughly recommend reading some of his memoirs. He's often on Radio 4 and on Radio 2, but his memoirs are very emphatic, they're heartfelt, and they're downright amazing. It makes me feel like a bit of a pleb working in breast work, rather than his neurosurgical work, which is really quite obviously cutting edge, and that our work is a little bit of a walk in the park some days, but his work he's truly an amazing person. But he says, medically we learn most from our mistakes, and that success is actually bad for us. So it makes us complacent and distorts our judgment. And the important thing about making more mistakes is actually admitting that we've made one. So in that sense, there's an onus on us as senior doctors to set an example of being really honest. So what mistakes happen in our world? Back to breast. A really obvious one is a wrong RR. Okay, return to screen. Okay, that could come up as an interval. It might be picked up by your second reader. It's perceptual or it's interpretational. Either way, it doesn't matter what happened, you missed it. There could be a communication error, written, verbal, really easy one. You biopsied the left breast, but you wrote down right on the pathology form or in the notes. You wrote in the wrong patient's notes. Something didn't get documented around the hormone receptors, those sorts of things. There might be a detection error when you're scanning somebody or looking at an MR. You didn't see that area of enhancement right down at the bottom in the inframammary fold on the final series that is actually a second cancer. You didn't pick up the really low lymph node because your probe didn't go quite far down in her axilla, so you just didn't see that node, and that was the one that was positive. There's a cascade of administrative errors that that can often be sort of looked back on as the Swiss cheese effect. Oh, that letter didn't go out, there's a little hole, something didn't happen. But when you put it all together, you can see a massive hole through the cheese, and you can see where that patient's care was really compromised. And prescribing errors, not necessarily related to most of our practice, but obviously as medics, that's the sort of thing we're thinking about. So what safety nets do we have in place in our world to make sure that these errors are minimised? We have double reading, and thankfully we do. There's work presented here this year to say that single reader pickups are about 14% of cancers in a screening programme. So thankfully we have double reading. And we have our MDTs where everything is scrutinised thoroughly. We review all our RRs from assessment pathway, so anybody not going to an MDT, we get a second opinion from another responsible assessor, and only in the last couple of years have we introduced the responsible assessor role. We've got our pharmacy and pathology colleagues, and we've got our patients. Following the recent screening incident, there are many women that turned around to the press and said, well, hang on a minute, I knew I didn't get my mammogram. I knew there's been an error coming. I rang the department and got my own. So our patients are one of our own safety nets. So why do medical mistakes happen? It's a lack of clinical knowledge. Okay, we don't know that calcification causes DCIS. We don't know that family history of ovarian cancer is related to this patient's breast risk. It's a lack of clinical skill. We're not able to take that tricky axillary ultrasound biopsy of an axilla, or as a lack of clinical experience to get that patient positioned for a really tricky stereotactic biopsy. No, it's not. We've got those skills in abundance. We're a great team. We've got people on the shop floor doing all of those things really well every time. It's the plate spinning and the crisis management that leads to the increased, caused by the increased clinical pressures we're all under. There's a massive clinical workload. The complexity and demands of our patients has increased hugely in the last decade, and we have to balance the department needs of working with a screening. In my case, certainly I work in a screening and symptomatic unit, which is all housed in the same very small footprint. We also have to manage, as doctors and as people, we have to manage our other clinical duties. We've got to keep up with appraisal, we've got to audit, we've got to teach, we're educational supervisors, there's service improvement, we've managerial responsibilities. Some people have on call as well. So there's plate spinnings going on. So what of all of those things that is going on is the straw that breaks the camel's back? I'd like to think you need to think of yourself as a battery, okay? A rechargeable battery that gets drained and that gets recharged. But as a human, you're not the battery that goes in your television remote control and that goes until it stops. That's exactly what we want to prevent. It's a continual cycle of recharging. And there are daily, weekly and longer term rechargers. And as we know, so thinking about it like that, a battery influences your performance. And if you have lots and lots of usage, you get a low battery and you get poor performance. And from that, we look at a human function curve. So, how that works. Over here, it's poor performance and not a lot of pressure. You're bored. Over here is what we refer to as burnout, okay? Poor performance because of too much pressure. And here is where we call a safe working zone. So you want to be working just before the top of your maximum performance, okay? Here is your danger zone. You're on the slippery slope down to burnout. But we know that that curve isn't static and it's liable to decrease. Your performance is liable to decrease by variable factors, most of which are these human factors. So what flips us into that work danger zone? We can separate them out into home and work things. So family issues, parents are ill, kids are ill, bathroom ceilings leaking, worries about money, worries about your own health that you're actually just keeping from other people that are niggling in the back of your mind. Things at work, that difficult interpersonal relationship you have with somebody in your team, constantly meeting targets and constantly meeting management requirements, the volume of work and there's deadlines, specific incidents, and that might be a complaint, it might be an ongoing case that you're just really that's struggling. It may be something that you've already done in the past, you've made a mistake and you can't let that go, and struggles with equipment, which are constantly sometimes breaking down. So you can put these two things in a set of buckets, okay? And the buckets are really easy to fill, but you put all your home things into your home bucket and all your work things into a work bucket. But once they're full, they're full. When they're overflowing, they're useless, they're not efficient. So do we have a home bucket and a work bucket, or realistically are we one human that goes to work and goes home? So what can we do about our buckets and keeping them from overflowing and keeping our performance better? Do you leave your bucket at the door? You go to work and you put your home bucket at the door, and you go home and you leave your work bucket at the door. No, sadly, that's not possible. And as I said earlier, I think we have one bucket rather than the two. We can empty them, okay, and that's what we need to then think about emptying them. So let's take an example of the Bawa Garba case, very well publicised over the last couple of years, where she was held accountable for a tragic incident in Leicester. It was this doctor's first day back after maternity leave, which, having recently returned from maternity myself, it's quite a stressful time. She was on call. It was a new hospital. Her consultant was off-site. There were very few other juniors around. She'd had no breaks. She'd had no induction. Fair to say, her bucket was full that day. And one of the issues I think of when I look at the case was her failing that day was not to stand up and shout very, very loud that there was a problem and that she needed help. That's very difficult as a junior doctor, to actually go and approach somebody and say, I'm out of my depth. It's your first day back. You don't want to be seen to be the weak link. You need to, in that case. So it's very, very difficult. But there was a lack of teamwork, which is essential for all aspects of healthcare going on there, and a lack of responsibility. And then we come to the consideration of collective responsibility of that teamwork for everybody who was on duty that day and everybody who's working on duty when we work on a daily basis. And that's the responsibility that we have collectively for our patients, for the working of the department as a whole, and for all, and for the people that we work with. So that collective responsibility issue has been raised by the aviation industry, and they were the first people to really look at human factors, and they found that 73% of aviation incidents were due to human error. So it's not because an engine fell off, it's because the pilot was drunk, it was because the pilot was going through a messy divorce or something similar. And they've developed a team approach to performance in so much as you'll have a senior and a junior pilot, but actually they have no hierarchy between the two of them when it comes to getting that plane to its ultimate destination. And the crux of all that comes down to safety. And for pilots, their endpoint is successful touchdown. For us, we have different endpoints of safety, but the crux of it is the same. And actually, if you look at the GMC domains of good practice, patient safety from your own health is one of them, that we must pose no risk from our own health, work collaboratively with our colleagues and act with integrity and honesty. So it all comes back to good medical practice, and is probably in all our trust values similarly. So what are these human factors that we talk about? They're the things that make us safe or unsafe. And if you think about the key objectives of any aspect of healthcare, it's to be safe, but it's also to be efficient. We can run a brilliantly safe screening programme by 5 readers reading every set of films and recalling every woman on one person's say-so. But it's dreadfully efficient, and it's never going to inefficient, and it wouldn't happen. So human factors are the influential variables of those people, and those are the key things. They're influential and they're variable. They may vary day to day, and the influences will also vary. They're the relationships we have with our equipment, our procedures, and our environment in which we work in, and our relationships, the relationships we have with the people that we work with. So in real terms, pink and fluffy stuff over, what is it? It's our experience in our jobs. It's the pride we take in our work. It's the bias. So, I've seen that before. I know what that is. It's going to be the same again. Well, always and never are always two very difficult terms that I was always told. Never, ever use the words always and never in medicine, because there's something that will usually or always catch you out. It's confidence, either a lack of or an overexuberance of, fatigue, mental or physical, work overload, status, who you think you are and who the people around you think they are, and that self-awareness and awareness of others. Awareness that someone else's bucket actually might be full, and that's why they're performing badly that day, which is impacting on everybody else and our emotions. So how does understanding these human factors affect you? Well, you need to understand that you've got a bucket. And that your own bucket, at some time, might be full. And contemplate that the people around you have also got a bucket, and their bucket might be full. Just talk to our colleagues sometimes if things aren't right. Ask them if you're okay. It's this sort of hidden taboo, the whole thing that's going on about mental health at the moment, just talking about things. And the appreciation of our performance curve and the fluctuations in it via these human factors. It all comes down to making our practice safer and more efficient, and in turn giving us a healthy workforce, which knocks on into less sick days for us all and a better working environment. So it's a positive cascade. And of course, the end point of that curve, which we never want to be, is burnout, and that's the end of the slippery slope. A recent survey shows that SAS doctors, which is most breast clinicians, that's the umbrella we work under, actually suffer the lowest rates of burnout amongst doctor groups. So why is that? Is it because, it's a pathway we chose, maybe we work part-time, but then so do other groups, a better life balance? I don't really know. It's certainly not through lack of clinical responsibility and decision-making, but we as a group apparently have low levels of burnout. That social level of burnout may be individual, professional, or organisational, and so we need to recognise when we're heading over the edge. That'll help And increasing resilience is a term, but I struggle with the concept of resilience because I don't want to put up a battle of armour and just be more resilient and take more work and take more things on. I actually want to get to the crux of why there's more stuff coming in with a workforce that's static. That'll help promote individual well-being, and I think we need to say no. So this is Sarah Millican, and I had a bit of epiphany when I went to see her in a gig in Bristol in March, and her words echoed with me quite a lot. And the 360-degree appraisal feedback things we have to do as doctors, actually one of the questions is, has the ability to say no? And so they recognise it as an actual thing that is good. But why do we feel really guilty and have to justify saying no? Someone says, oh, can you just do this? And you're like swamped. We should be able to say no. There's not unless it's really urgent, we should be able to say no and not say because. And Sarah Millican came to this conclusion in so much she was asked to a Buckingham Palace garden party with the Queen, but she said no because she was picking up a new kitten that day. And she felt the need, she had to justify it, and she thought, no, I'm not going to do that. And she just looked her agent in the eye and said, no, in a very Sarah Millican way. And at the end of the concert, end of the gig, she hands out little badges if anyone's ever seen her. And one of them was a badge that says no on it. And I couldn't get enough of them. So I picked up 3, and they sit on my desk, and they sit on 2 of my colleagues' desks, just to remind us that we don't have to say yes to everything. And I've put mine on today, just to remind me. So saying no is a good thing. So going back to that battery, what are the things that drain us? And it's anything that fills your bucket, which results in a poor performance, individually in the team, compassion fatigue, and risks to the safety and efficiency of our service. The daily drainers we can think of as being hungry. We don't perform very well. You're angry about something or you're late. We've all done it. We're running into clinic because something's happened. You're running late. You pick up the first set of notes, crack on, think, right, go and scan it. You didn't take time to just look on the other side of that notes and note something really important. And then all of a sudden you're digging your size 6s out of a little bit of a pickle in that ultrasound room. So just take a breath. You're tired, you're emotional or distracted. Again, you're reading a set of films, someone comes in. Oh, could you just have a look at this for me? And you go back to those films and, oh, did I look at that one? Did I press go? Oh, you're not really sure where you are. And mistakes happen. And think back to those mistakes you were thinking about at the beginning of the session, and some of those may be very much the reasons we've listed here may account for them. And that makes a nice little acronym of HALTED. So think about those things on a daily basis. So what about our rechargers? So it's anything that empties your bucket. Nice things, holidays, weekends, just things that make us happy, our well-being. And these are the individual things. But actually it doesn't necessarily have to be things outside of medicine. Appraisal can actually be quite an enlightening and a good battery charger if it's done well. I can see some curled lips there. Sorry, I'm probably out on a limb there, but I actually find it sometimes it's quite empowering. Conferences, courses, we're all going to go back oozing with enthusiasm and going to want to change the world and change our own department. But these sorts of things are good. Getting some good feedback, saying well done to your colleagues when they've done something well, may well help empty their bucket that day. And accepting and forgetting some things sometimes. Actually, all right, I'm not going to let that eat me up. I missed that cancer. Okay, fine. I found another 4. I need to move on. I'll learn from it. Mindfulness and exercise. Liz made comment to that this morning. And then we've got our team things, our debriefs, our meetings. Meetings can sometimes be a drainer, not necessarily a recharger. And then we've got the realm meetings, which are the radiology events and learning meetings. So I nearly forgot that one. And then understanding our team in those meetings and the fact that we're all different. And actually that's a good thing. Continually to have dialogue with other parts of our systems that we work in, making compromise, coming up with a solution rather than going into a meeting and into a dialogue, rather than going in there with a problem. Think of a solution and think about your own job plan. If it needs to change, take responsibility for it. And the purpose of that is, again, improving safety, improving our compassion and quality of care and staff well-being. So think about you. Think about a single thing you would like to change. Or probably more realistically, single thing that you could change. And something that constantly fills your bucket. So you think about what the issue is and what your end goal would be. And then you have to break it down to look at the reality of actually how can I do that? What can I, is that feasible? And the steps and the options around getting to that goal. And then from your options, what, how, who? Who are you going to contact? Who are you going to help you solve your issue and reach your goal? Because if this is something that constantly fills your bucket, you need to address it. There's probably no quick fix to it, and there's support available. Support for doctors is a massive amount of support for trainees. But as soon as you cross the divide and become a consultant, it's like, yeah, big wide world, crack on. And for us as SAS doctors, again, there's less around as well. But we do have the SAS Charter, and I would implore any of us working within this role to read that. And that sets out our roles and responsibilities. And you can use that as a little bit of, not a bargaining tool from a point of view of your job, but I think it's a really important document that we should be aware of and we should read, and that's been written by the BMA. Self-care, there's a number of self-care workshops, those sorts of things, and team care that we can think about. Mindfulness is very, very on trend at the moment. There are a couple of apps that we can use for that, and it may be that taking 10 minutes out at lunchtime, going for a walk around the block, or just taking 10 minutes away from your monitors, away from your patients, and sometimes away from your colleagues, is actually just gives you that little bit of downtime and just gives you that recharge. And of course, if things get really bad, so that we're at this point on the right where the headlines in The Guardian say that doctors are at burnout, and that's actually relating to juniors, not even to senior doctors. There's obviously our GPs and our Rocky Health team. So remember that you're human, and that mistakes are sadly inevitable, but some of them are avoidable if we almost just slow down a little bit, which is difficult in the climate that we work in. Think about our environment and making small changes at a time. And I believe we can be better at what we do, not purely by increasing our knowledge of the technologies and getting loads of new kit like we're seeing this week, this couple of days, and the stuff downstairs, but actually just looking after ourselves. So the cup of tea is always a good thing. We're British, we drink tea. And a friendly reminder that doing your best does not mean working yourself to the point of mental breakdown. So in summary, work out what is in your bucket. Think of how you can keep it from overflowing and keep yourself in that safe zone of work. Say no, not to everything, but to things where you think that's not going to make a difference and I need to concentrate on doing something else at the moment. And look out for those struggling colleagues and have those conversations. Read the SAS Charter if it's applicable to you, and constantly think about our safety and efficiency with regard to the issues that are affecting you in your daily work. And to end, we must remember that to err is human, but to forgive is divine. Thank you.